COVID as per even normal people can get COVID, but burn patient being immunocompromised, the chances of acquiring the coronavirus is much higher. And the risk is from various sources. One, either from the patient directly acquires from the relatives or from the staff members, or overall from fomites which are there in the burn unit. Now, as the coronavirus gnaws its way across India, Mumbai has suffered the worst. This city of 20 million is now an epicenter of this disease and now responsible for 20% of India's coronavirus infections and nearly 25% of the deaths day after day. We have observed that during this phase of COVID, the industrial burns are down because industries are not working, and domestic burns and scald burns are up, possibly because the men folk and the children are at home. And more cooking is being done to satisfy the needs of the people at home. And overall numbers of indoor patients are down. Routine surgeries are not being performed. As a general policy, every new patient to a burn unit and his relative has to be considered as a potential COVID patient, and appropriate preventive and protective measures are taken, which I'm sure everybody is aware of by now. As far as relatives go, we try to restrict the number of relatives accompanying the burn patient to only one per patient if it's an outpatient. Outpatients are called in only if there are acute burns or with wounds which require dressing which cannot be managed at home by the patient's relatives. If they're small wounds, the relatives are taught how to do the dressings and they manage the wounds at home and send pictures on WhatsApp. If the patient is hospitalized, only one relative stays with the patient, no visitors allowed to come in and go out. The relatives are made aware of the precautions to be taken in terms of washing hands and wearing protective masks and spacing out the OPD timing so that there's no crowding during OPDs and social distancing is maintained to prevent the transfer of the disease. As far as staffing goes, arrangements have been made in our hospital. We can be telling you what we have done, changes we have done to prevent the transfer of the disease. Arrangements have been made to house most of the staff in the hospital premises so that not many staff members come from home. Training programs of the staff regarding COVID-19 and the protective and preventive measures to be taken, hand washing, social distancing, donning and doffing of the PP, these ongoing programs on a weekly basis are being conducted. Training programs are also being conducted to ensure more staff are aware of methods of non-invasive ventilation, invasive ventilation, apart from the ICU staff which are already there. This is just to ensure that there's a backup team available just in case some of our ICU staff acquire or contract with the COVID disease. Rotation of staff being done since the staff is staying at shorter hours and break duty wherever possible, because it has been said that longer hours with the PPE are very difficult to manage, and also the efficiency of the staff goes down. So 4-hour duty followed by a break again, followed by a 4-hour duty. This is the donning and doffing protocols which have been put up all over the hospital and can be put up by all the burn units so that the people are aware there's a particular technique of putting it on and particular technique of putting it off so that you don't get infected, neither do you put others at risk. There are certain additional instrumentation which are we have found useful from the literature that we have been reading on it, is the use of non-invasive ventilators. Non-invasive ventilators have been found to be more useful in case of COVID disease, in case your burn patient acquire the disease, rather than intubating them. If they can maintain their saturation with a non-invasive ventilator, you don't really have to put the patient, intubate the patient and put on ventilator. Nebulizers are to be avoided because they generate aerosols. So fixed dose inhalers are to be used instead of nebulizers as far as possible. High flow nasal cannulas are special devices which give high flow or nasal oxygen from 6 to 26 to 30 liters per minute. And they are found to be very, very effective along with either as a substitute for non-invasive ventilation or as a substitute for invasive ventilation, wherever the saturation can be maintained with high-flow nasal cannulas. Video laryngoscopy has found to be very useful in intubations, wherever intubations are required, either as an emergency in the ICU or while intubating for a surgery. And this avoids direct exposure of the anesthesiologist to the patient's breathing. And acrylic box has found to be useful, which is easily available, at least in Bombay. I'm sure it's available all over the country. And With the video laryngoscope, the anesthetist can have a look at where the vocal cords are and how to go about the intubation, either directly with an endotracheal tube or with the use of a stillet. All skin banking activities have been put on hold. In India, all organ donations have been tentatively put on hold by the Zonal Transplant Coordination Committees, ZTCC. It's not safe to go to people's houses or mortuaries or hospital ICUs to harvest skin for fear of COVID, both to the staff, to the relatives who are there, and we're not sure yet of the protocols of how to ensure the safety of the recipient in case skin is harvested from even a non-COVID patient. He may be an asymptomatic carrier. There are special protocols being formulated, which maybe in a subsequent webinar we could discuss that. The donor COVID status is difficult to assess, so we are trying to work out these protocols as I mentioned. Surgeries, only emergency surgeries in burns, limited elective surgeries, covering all fresh burn cases, biological dressings so that the frequency of dressings is reduced. Acticoat we have found to be useful even otherwise, and I agree with Dr. Ravi Mahajan that Acticoat is used and we don't have to change it frequently. So the exposure of the patient and the staff to each other will be reduced. In the visits to the OT will be reduced for the dressings. The chance of cross-infection are also reduced with Acticoat. Early excisions have been put on hold due to shortage of skin allografts. And the number of surgical procedures we try to reduce so that the less surgeries being done, less chances of acquiring COVID, especially for the anesthesiologists. So at the time of intubation and extubation, the least number of people remain inside the OT. So that, but that's the time when the maximum aerosol generation is happening at the time of intubation. And we try to do as much as possible in one operation. This is the flow chart suggesting COVID-19 testing protocol for planned surgical patients in burns. A PCR testing and antibody testing should become mandatory. If the patient is PCR negative and antibody positive, that means the patient is well immunized, the disease has come and almost gone. The surgery can be carried out, no testing in the duration of stay, and even at discharge, no exit test is required. If the patient is PCR negative and antibody negative, that means patient has still not got the disease. One can carry out the surgery. PCR testing will have to be done during the period of stay, and every 6 to 7 days, because the patient is in the window period, the PCR may come positive later on. And at discharge, an exit PCR test should be done so that the patient knows that patient was COVID negative when he left the hospital, and the blame does not come on the hospital for transmitting COVID to the patient. And the last possible combination is PCR positive and antibody negative. We have to postpone the surgery because it has been found that patients who are PCR positive, antibody negative, in the active phase, the complication rate of the surgeries is much higher. Patients don't do that well, the grafts don't do well, and the recovery is not. So it is better to wait for 4-5 days, let the PCR become negative, and the antibody start becoming positive. That's the time to go in for surgery. Anesthesia, intubations generally try to avoid more of regional anesthesia, intubate with full relaxation dose, intubate with acrylic box, intubate with video laryngoscope, and extubate the patient, try to extubate the patient deeper plane of anesthesia to avoid the patient struggling and coughing, where more aerosols are likely to be generated and chances of infection are higher. To conclude, the burns management in the post-COVID era will need all of us to make changes in our treatment protocols as per our infrastructure and availability of staff, personnel, and instrumentation as we go along. We're all on a learning curve, and each one of us will have to customize a protocol depending upon our infrastructure, both in terms of personnel, equipment, and finances. I think it is only by sharing our thoughts, ideas, and protocols with each other will we be able to move faster and more efficiently with newer protocols to save the lives of burn patients without compromising the safety of our burns team. Thank you, ladies and gentlemen.